and thank you for joining us for another episode of the Seamless Connection podcast. I have with me today two of my most favorite hospital leaders. I have Dr. Gretchen Nickell, CMO at East Liverpool Hospital, and Lorie Herrman, CNO at St. Joseph's in Missouri. Welcome to the show.
Thank you.
Thank you.
So glad to have you both on with me today. One thing I wanted to start with is just to introduce you to the audience, because I know you both have had very different career pathways that brought you to leadership positions in your communities today. And I'd love to just start with what brought you to healthcare first and what brought you to your particular roles as an add-on to that. So maybe, Gretchen, if we could start with you.
Oh, sure. What brought me to healthcare is just I always knew I was going to be in healthcare, and from a very early age knew I wanted that to be as a physician. So I stayed local for medical school in Ohio, where I grew up. And after that, stayed local to do my residency in internal medicine at a hospital about an hour north of where I currently practice. And incidentally, where I currently practice is the town that I grew up in and where my family resides. And that was always a goal of mine, to be able to work in this specific hospital right here at home. It never was possible at first for the first part of my career because they did not have a hospitalist program here. I'm a hospitalist physician. So I spent the first 8 years of my career to the north, where I did my residency, very comfortable, like home. And then when the opportunity arose here at East Liverpool for me to help start a hospitalist program, I jumped at that opportunity. So came here, helped them get this program off the ground. One of the things I missed at my old program was we had a residency program. And I found out very soon after coming to East Liverpool that it is a good hospital to have a residency training program. So we were able to establish that here, and therefore I didn't have to miss anything at my previous site. And we've had a residency program here since 2012. How I came into a leadership position was a little bit different. Was always in some role, whether it was the assistant program director or program director of that residency at my last site, and currently as a program director here. And I held various chair positions, chair of the department. And then our hospital, who was independent for a long time, joined Prime Healthcare. And Prime Healthcare has a model with a CMO where they really do encourage their CMO to be a practicing physician, so that you have somebody that's making those decisions from an administrative standpoint, who also is in that role and is at bedside and knows how those decisions can affect the care that's delivered to the patient. And I was fortunate enough to be offered that position when Prime Healthcare took over East Liverpool, and I took that position in 2016 and have learned an awful lot about the administrative side of medicine since then.
No, that's fantastic. Thank you for sharing that. And before I dive into questions, Lorie, would love to hear the same for you.
Sure. Well, I had always wanted to be a nurse, actually. I've always admired the profession, and I love obviously helping others and developing others. I actually went to school as a non-traditional student. I've been an assistant chemist in the lab and done some other things, administrative, just a very career path, honestly, before I actually dove into nursing. And as a non-traditional student, I actually had children at home. I became a nurse, and it was a wonderful profession. It still is for me. I started in the ICU and did neurosurgical ICU, and then went into PACU at some point. That's kind of when I got pulled into leadership. I had had prior leadership experience in other positions in other fields. So it kind of was a natural gravitation. It wasn't something I was looking towards doing or that I chose, kind of chose me. It was a tough transition initially because I just loved doing the patient care side and being a patient advocate. But I soon realized that as a leader, I had the ability to really influence and make changes that supported the team that actually take care of the patients. And I always say that, I will stay in a leadership role so long as I'm able to continue to impact that and be the advocate for all the people that do the hard work that take care of the patients. With Prime Health, it's been interesting. I've been a CNO of a more rural hospital, I guess, at St. Mary's, just east of here, for a few years. And then I did a regional role, and I actually met Gretchen through that time, where I was kind of overseeing 9 of our hospitals in a couple different states and traveled for a few years. prior to coming back into a CNO role, both at St. Mary's and now in Kansas City at St. Joseph Medical Center. And so I love what I do, and I just look forward to impacting healthcare in a positive way for years to come. So
That's fantastic. So both of you work in communities that are very different on face, right? But you are probably seeing very similar challenges, I would guess, just based on what I see at various hospitals around the country. Can you tell us a little bit more about your specific communities? Just because I know Gretchen, East Liverpool, a little bit more rural, right, than many people
Very,
might
very
be.
rural.
Very rural compared to
Yeah,
about 40, 45 minutes outside west of Pittsburgh.
right.
Gorgeous to drive out there, but I know there's very little around
Yeah,
once you get there in terms of resources for your community. And then
yeah.
Lorie, I know I've known you from your time at St. Mary's in between and then
sure.
now back at St. Joe's. Would love to kind of get your thoughts on the communities you've served versus where you are now.
This town is the hospital itself is in a underserved town, underserved community. It is a rural designated hospital. We are located on the Ohio River Valley. We're actually part of Appalachia. We're one of few programs in the country that have a residency program located within Appalachia. So the community itself is underserved. We're able to utilize different resources due to that status, which is helpful. Where it can create a problem of being medically isolated is we're blessed to have a lot of primary care in this area, which is key. Primary care is really the first step towards entry into the healthcare system, of course. So thankfully, we're not underserved in that region at this point, but where we are underserved is for specialty care. It's difficult to get that specialty medicine when you need it here locally. And while 45 minutes or 45 miles is not always a burden to many communities, to our community, it can be. So we have many of the patients that we serve do not have transportation or they don't have reliable transportation to go a distance. And the next closest hospital to our hospital is about 35 miles in either direction. And so by the way the road takes you, you're looking anywhere from 40 minutes to about an hour to an hour and a half if you're heading into downtown Pittsburgh and you happen to hit any traffic. So we're isolated where we are.
Oh, that makes sense. And Lorie, how about you? What are the challenges you're facing there or have faced throughout kind of the different locations?
Sure. Our challenges are a little different. We're in Kansas City, which has many resources here in Kansas City, lots of hospitals and health systems. We're kind of on the south side of Kansas City, and we're a hospital celebrating our 150th year here. So, been definitely a pillar in the community. I would say our challenges are kind of gaps in care. While we may have some specialists, we have times where, they go on vacation or there are things that are come up. And so we really utilize or focus on, the telemedicine part really to help us with those gaps in care. I would say that's a big part of it. And then, of course, anything and everything that everyone else is experiencing in healthcare are certainly our challenges too, with difficult payers and lots of those kind of challenges. But I would say related to telemedicine or just physicians in general and specialists, that it would be gaps in care would be a big focus for us.
No, and that makes sense. And have as Prime has as your hospitals have joined the Prime systems, and I don't know if St. Joseph and St. Mary were already in the Prime system, Lorie, when you started with them, or if they joined later.
I was working at St. Joseph when we were acquired by Prime in 2015. And so I actually moved from St. Joseph over to St. Mary's as CNO over there during that transition time.
Okay, great. So it sounds like
Yeah.
you both entered the Prime kind of family at the same time, roughly.
Yeah.
And I know Prime prides itself on helping hospitals in underserved areas or in areas where
Mhm.
they are missing some resources and helping kind of to bridge that gap. As you've been working through and delivering the needed services to your community, what have you found as most successful to help, make the biggest impact for your patients? But I also want to have you guys think about it from the provider perspective because you guys are both providers. And to your points earlier, just seeing that impact from a provider perspective as well as meeting the needs of your patients is really key to providing that comprehensive healthcare experience that's so critical for a local community hospital.
Yeah, I think for us, one of the things that we realized is how important that transition of care is. Because as I said, we really are the only inpatient facility in for miles around. And again, many of our patients don't have the ability to go to another hospital regardless of where it's at. So what we saw is a need to make sure that transition of care is seamless. So we really need to have a good communication because communication is the key when it comes to transitioning that care from the outside world to the inside world and then back again to that outside primary care provider. So I think one of the things we do that helps our patients the most is having a very good open line of communication between all the providers and as well as all the hands-on care providers with nursing staff and other staff that is involved in the care of that patient. So in a small community, what can be maybe easier than what you might be able to do in a large community is have a connection. So the inpatient doctors like myself have connections with all of the outpatient doctors. They have my cell phone. They can call me, and they do call me and say, I see that you're at the hospital today and I'm going to admit this patient and here's why. It's a great start for me to know and understand why that primary care doctor who knows that patient the best wants this patient to come into the hospital for a higher level of care. And at the same time, once that patient leaves the hospital, however many days later, to be able to transition that by communicating what was done in the hospital and what I would recommend still be followed up outside the hospital helps to close those gaps so that everybody's on the same page with what that patient needs for their care. Additionally, in a hospital like ours, where we are underserved and have that rural designation, we can offer certain resources that you can't if you weren't a disproportionate share hospital with a higher number of Medicare or Medicaid patients. So we can offer things like reduced visits, cost of visits to a rural health clinic. We can offer programs that greatly reduce the price of medications for our patients. And that's for ongoing care. So that's not just when they leave the hospital with one prescription. It's to be able to say, if you can't afford your insulin, as an example, we have a program where you can get that insulin for literally pennies on the dollar to help for that ongoing chronic management of your chronic disease.
No, that's fantastic. Lorie, I'm guessing it's going to be slightly different for you being where you are in more of a major metro area. Are you able to utilize do any of the lessons and approaches that Gretchen mentioned apply in your situation where you're more urban?
Yes, they do. I mean, we still have a large population of Medicare, Medicaid patients, and there are underserved people in our area. A lot of, mental health, poverty, homeless, those kinds of things. And we are very challenged with that population in just trying to get the resources for after the hospital, to Gretchen's point, post acute stays that are needed, those kind of things. We work very hard for our own internal acute rehab facility here that we do serve Medicaid patients on the Missouri side, and we're working to get that for the Kansas side as well, because that greatly helps them. Those patients that we know are going to leave, and if they don't have some kind of care to get them stronger and ready, they will fail.
Mhm.
And so, fortunately for us, Missouri has expanded that Medicaid about 18 months ago, and it's exponentially helped us so that we can extend services to those patients. But
Mhm.
we do a lot of the same things with the prescriptions and things. I mean, it's expensive for the hospital, but we do what we need to do to make sure that patients will be the most success upon their discharge. And then trying to get them connected to PCPs. That's the next phase. And we're looking at a residency program in 2025 summer, starting up internal med. And we're actually going to open up a clinic to kind of do that aftercare for them, for those that don't have a PCP, which is going to be really fun. And we're starting that up a little sooner than the residency program. So the physicians have all volunteered to go ahead and work that. So that's really great. So that'll
That's
hopefully help
fantastic.
those
Yeah,
patients too.
that's such a great news. I know at East Liverpool the residents are such a huge part of the care
Huge.
Oh
delivery
yeah,
on the inpatient. I know they
Yeah.
have the resident
yeah.
clinic to help, like you were mentioning,
Hmm.
Lorie, they see a lot
Yep.
of patients in the community, and it really
Mm-hmm.
helps bring them in. And I think, correct me if I'm wrong, Gretchen, but you guys use that also as a great recruiting tool, right? To have them
We do.
see life in, where you could
Yep.
be practicing, which is great.
Right, we do. And it's been a successful recruiting tool. Actually, all of the hospitalists, except for myself, are graduates of the program.
Oh, wow. I didn't know that.
Hmm.
That's
That's
exciting.
amazing.
That's
Hmm.
good to know.
Yeah, and the really wonderful part about that, I mean, that's not why we started it, but what a perk. And the really wonderful part about it is that they grew up medically here.
Yeah.
So they know this town, they know this community, they see the value of working in a community like this. It's no surprises.
Hmm.
So they go from Friday being a resident to Monday being an attending, and
Exciting.
it's yeah, it's an easy transition to a scary transition in their lives.
Yeah, that's great.
That's fantastic. Lori, I know that St. Joseph's is one of the few hospitals left in the area with an inpatient psychiatric unit. And we all
Yes.
know the mental health needs around the country. How do you manage that? How do you manage keeping it open, balancing the needs, the ever crushing needs for a bed, and balancing the needs of the community versus, there's only so many beds, I know, and you guys are pretty much always full. So how does one think about that in a resource constrained environment? I know you mentioned telehealth for specialists. Both of you, I know, use telehealth in various creative ways to help make sure your community and your hospital are getting the needs met. But in a situation like that, which is very intensive and different than a typical, virtual care use case, how do you balance the needs and the resources?
Well, it's a good question. So we, just like East Liverpool, we actually have a Jerry Psych unit here, and it's been here for I think about 4 years, 3 to 4 years, and we've had our challenges up and down, with census. We're actually COVID kind of hit us, a little differently. We went through some unique challenges. I actually wasn't here during a lot of that time, but I understand and learned about it. We have a new nursing director and are getting a new medical director coming up. But the challenges are is that you get one medical director and you really have one physician assigned, and that's kind of it. And they need their time off, and this and it's very challenging when they're gone. And we have a very dedicated person he's leaving. He's going to do new things, but we will have a bit of a challenge with our new person coming on because she's just going to be available, basically Monday through Friday. So I think that's where we're kind of partnering with Amplify, to look and see if there's options there. And we utilize nurse practitioners too. We have quite a few of those. But again, it's just really using all the resources. I mean, it's like seeing what's available and making sure that we don't have any gaps in coverage, because there can't be. We have patients in here all the time, and
Mhm.
you never know what's going to go on, what you're going to need. And we want to be able to admit patients 24/7, because when there's a need, we never want to turn away a patient that meets, the basic criteria for the unit. So that's probably our biggest effort. So we're in transition, but we believe that having what I like to call buckets, different buckets to pull resources from, we'll have at least a good three of them. And I think that we'll be able to, provide the coverage we need for all the patients. So.
That's fantastic. And remind me again, in terms of virtual care, I know obviously the areas we work together in, but I know that St. Joseph's and Prime more broadly have virtual care across a number of different specialty areas: telestroke, infectious disease, hematology, oncology, psychiatry. What are the ones that you find most useful at your each individual sites, and how are those resonating with your patients? I know during COVID, everyone accepted it because that's just the way it was. But since then, has there been any
Mhm.
pushback? Have people been like, wait, I want to see, a quote unquote real doctor, versus they're happy to get, high quality care, even if it's virtual? How have you seen that?
I actually have not seen any pushback. Um, and most of our telehealth, I believe, was really initiated um, a little after the pandemic, or some were before. But yeah, we have several services. So we have infectious disease, hematology, oncology. We have critical care medicine and neurology. And I have not witnessed any pushback from the patients. Our patient population generally wants to stay here. They want to stay local, mostly because they don't want that burden on their family. So they want their family to be here. It's certainly a community, definitely a community with strong family roots. So the folks that are here have been here for generations. So you see where multiple generations come in and they're part of that care of the patient, thankfully. So to take that patient and transfer them to a larger center for any of those specialties we talked about,
Mhm.
neurology, or any of them, critical care especially, creates a burden on the family. And then that creates a burden on the patient. So it's always best if you can keep the patient where their family is. So we have not witnessed any pushback. Actually, I think our patients find it to be fascinating that they're able to utilize something
Mhm.
of this caliber of technology. They really I think they're impressed when they see that we're able to offer that to them. I don't know that I could say one service is more valuable than the next. Certainly, having access to telestroke so that we can treat those patients right here, right now, instead of having to get the helicopter here immediately. And if they would need to have that immediate treatment, and in order to transfer and to be able to keep those patients is phenomenal. Um, Critical care medicine, to be able to have those patients here and see that critical care doc virtually, but not just the patient. These doctors will talk to the families too.
Mhm.
They do everything as if they were there in real time, except examine the patient, which they have the doctors there that can do that for them, and they can use the nurses as extenders if needed. And what I would say adds value to all of these services that we have now from a virtual standpoint is that a patient can say to me, I really would like to be transferred. I'd rather not have the virtual care. I'd like you to transfer me. Prior to COVID, that was never a problem for me. I could get a patient transferred to a tertiary center of their choice in usually under 4 or 5 hours. Now, because everybody's facing the same staffing issues, no matter if you're a tertiary center or a small community hospital, transferring a patient to a tertiary center is not what it once was. So I'm not looking at a 4 to 5 hour transfer time. I might be looking at a 4 to 5 day transfer time.
Mhm.
So this changes the game to be able to provide that care. They don't, not only do they not have to transfer, but they'll actually get that care. So without that, it's not even a matter of trying to them to not have to transfer and being able to stay. It's a matter of them just getting that care.
And Lorie, how about you? Are there other virtual care resources that you guys are using at St. Joseph's or any of the other hospitals you've worked at or supervised at?
Well, I'm going to speak a little bit about St. Mary's because that was, a hospital that at that time we really needed some help. We're high mental health patient load, and we would always board, like up to six patients in our emergency room at a time. And, it just seemed like such a disservice. We didn't have psychiatrists that could come around or do anything. We do the first assessment, through, and then they'd be waiting for placement without real good treatment, because we had the ED docs taking care of them and, all those kinds of things. And they did their best, but not really someone with that specialty of the psychiatrist. So getting that service at St. Mary's was wonderful. And I will tell you that there were times we were able to treat in streets so they could go outpatient and get their services. So it just became such a wonderful thing to be able to actually get them back on meds that would work and start getting them to a baseline point to where they could actually go and get the treatment, an outpatient, not disturb their life. The other thing that was really great was infectious disease. We had a big group that we shared between the two hospitals, and they had a provider who retired, and they were unable to cover St. Mary's just because it was so far east from where most of them resided. And so we were able to set up the telemedicine for infectious disease. And at first, I will say the hospitalists were concerned because it was actually during COVID, which seems very vulnerable. But what was so great is they had one physician assigned, and she was very wonderful in establishing a rapport with the physicians. And they all really enjoyed that they had the one provider for this service line. And it really became just a great, partnership, and really saved us through a difficult time.
Hmm.
So, and I would say at St. Joe, again, it goes to the gap of care. I think they're all good. I like that intensive care, the tele part for that, because again, that gives nurses the ability to call someone anytime, any day. They always have a resource available if they need it. So we're still benefiting here over at St. Joe for all of our, different specialties that we have too.
That's fantastic. If you're talking to hospital leaders who are looking to potentially add virtual care, I know most hospitals, so I think there was a survey out recently that said about over 90% of US hospitals have some form of telehealth, but most of
Mhm.
the time it's actually in the ambulatory setting, right? It's
Mhm.
still relatively new or novel to have it in the inpatient setting
Sure.
besides telestroke, right? Telestroke,
Mhm.
telepsych in the ED has been around a
Sure.
little bit longer. But conceptually, if you're talking to hospital leaders who are considering this as a way to solve, like you said, gap issues or to solve the access to specialists just not being available in the local community and to be able to provide that care, what are some of the lessons you've learned along the way? And what would you say to someone in your position before you had those resources?
I think for me, the biggest lesson is, and this wasn't learned the hard way. This was incorporated from the beginning, and that was working through those that brought that telehealth to us, was
Mhm.
rolling it out appropriately. It's about educating the staff in advance on how the process works and also the technology, and being able to start talking to the patients to say, what does that dialogue sound like when you're explaining what this new process is going to look like, and also establishing that communication with those providers. As doctors, we're used to seeing that consultant in the doctor's lounge or in the hallway or while we're both rounding, and then being able to discuss that patient. Yes, we write notes. Yes, we communicate in that regard. But there's also something to be said by having that face to face with that consultant that you're utilizing when you're getting that expert opinion. So, having that open line of communication that we have with all of the doctors and advanced practice providers that provide virtual care for us has been very, very important in making this successful. Much like you're saying, you had that one ID doctor, and we have that too. We have a set of folks that provide the care for most of the services, and we have their cell phone numbers, and we can call
Mhm.
them and just if we have a question, we can ask them, and it's very convenient. It's really surprisingly looking back on it now, knowing what I know now, would I have said I would have felt like these are colleagues that I interact with at the hospital? I probably would have said no, but now I can tell you it's really very much the same. I have the same access to them that I have with colleagues that are here physically.
Mhm.
So I think getting those providers together ahead of time is a good lesson if you're starting to bring somebody on. Having those providers meet your current providers ahead of time to discuss it, to say what does it look like and how do we do this and what will my notes when will my notes be populated and how do I reach you if I need to?
No, that's great. Lori, do you have anything to add on that front?
Well, I think she said it so well. I would just say for all of those, any critical access hospital, I think it goes back to what Gretchen said. If you don't have certain specialists, you're going to end up transferring certain patients, right? And that's going to be a
Mhm.
dissatisfier, and for many reasons. And so I do encourage, check out and see what's available because there's lots of different models, for pay structures and things like that that could work. And it certainly could just be a great adjunct for the physicians that are working in the hospital. And maybe, you could keep some of those patients without having to transfer them out. Even on any patient that we have to transfer out, you just never know. It does delay. It's never quick. It seems like, even um, just serious cases, especially during COVID, we know that there
Mhm.
were, bad things happened because patients weren't able to get to where they needed to go. So if there's any way to bring in some help, in these other modalities, it'll probably just be a win-win, I would think.
No, that's great. And I know people always love hearing stories come to life. Do either of you, or hopefully both of you, have an anecdote you can share about a situation in which the virtual care resources that you guys provide at your hospitals to add resources to your community really impacted a certain patient or a certain family to kind of really highlight what can be done?
I have many actually. As I said, this technology was so well received with our patient population that it's very common and very frequent that patients and or families will say how much they appreciate not having to leave.
Mhm.
We and from a physician standpoint, we really do have a wonderful group of patients, and this community is a community that very much appreciates the medical care that they receive. And I have had patients prior to having access to telehealth that needed to be transferred, and the patient and or the family would deny the transfer very kindly, very much say, "Doc, I trust you," or my partners, "We trust you. Just you continue to take care of me. I don't want to go anywhere else." And while that's a wonderful sentiment to hear from a patient, it's also concerning because there are times when we truly want and or need expert opinion. So to be able to say to that patient who these are longstanding patients or generational patients, their mom was here and they knew that we had to transfer their mom, or the last time they were here with whatever that ailment is, we had to transfer them. So when I say to them, "No, I don't have to transfer you now," they're overwhelmed with joy to be able to stay here. So that's a frequent occurrence for us. Another one that happens, has happened more than once, that I get such great feedback from my patients, involves HEMONC. So we don't have any HEMONC in this town. We do have it in the county, but it's of course on the opposite end of the county.
Yeah.
But not only do they then be able to have an evaluation by a hematologist or oncologist, then I've come into the room and they explained to me that that hematologist oncologist they saw virtually took the next step and contacted that hematologist that's on the other side of the county and told them all about the patient and got the ball rolling with that follow-up with that hematologist oncologist. So they see that continuity of care and they're so impressed with that. And that obviously helps us with the transition too.
No, that's great. Lorie, any particular stories stand out in your mind?
Yes, I mean, first I'm going to say that most of them initially were around mental health because I have a passion for that population, and I just was so impressed by the ability to treat people instead of just holding them, there for days without treatment. So there was multiple of those, but the one that just happened last week that was really interesting. It is about a code stroke, but our ED medical director actually took the bot with him into CT and had an 18-minute door to treatment time, which is very impressive. And of course, it's all been kind of a fun, friendly competition. We always want to make sure we do all the right things, but it was just very impressive. And so it's kind of becoming a best practice is that, when they actually go roll the CT, that we're going to see if the ED doc can just grab the bot and take it with them. And then that way, that physician and the ED physician, they're right there. They can look at the CT together and determine, TPA or nay, or, and treat. And so that was very exciting. And everyone, was pretty celebratory over that 18 minutes. So
Yeah,
it's
that's
good
worth
stuff. That
celebrating.
doesn't happen. That's a rarity, but he was pretty proud of himself.
And something that we see here that Lori, you will hopefully be seeing soon too, is the education that goes on with this for the residency
Oh,
program.
that'd be great.
So in the intensive care unit, we have a resident that's manning the computer and going from bed to bed and being able to give that report to the teleintensivist and discussing that case in real time with that family member there or the patient. So they're really having this open dialogue, so the patient and the family get to be involved with the teaching with an expert to a resident, which doesn't happen all that often. I can also see that with our infectious disease rounds as well. So being able to see that ongoing education on a virtual platform, let's face it, that's going to be integrated into medical education as we move forward in the future. And to be able to see it now, it's definitely satisfying.
It's
No,
great.
that's very cool. It sounds like you guys have done so much to level up, if you will, kind of where your hospitals were to where they are today, and I'm so thankful to be part of the stories, even peripherally, and to hear about them peripherally. But one of the things that I get asked a lot, and I see a lot with hospitals of all sizes, especially today, is budgets and financial realities, right? As you both, I see you nodding your heads, and I'm sure you struggle with that all the time. Um, through COVID, and especially once the pandemic era, federal government subsidies went away, it was really hard financially for a lot of hospitals. And I'd love to see how your hospitals were able to continue to provide such high level care, develop such amazing programs, such as the residency programs, or plan to start new residency programs, and meet the needs of your communities when all across the country we just saw red. Right, it's negative operating margins, negative budgets, negative income. And from everything I've seen, your hospitals have not suffered, and they've been so well managed through that. So I'd love to, if there's any piece of advice that you could, again, on that front, that you can share on how you were able to manage through that and how you were able to balance financial realities with all of these new programs you're talking about is so critical for the community. How were you able to make it work?
That's a big question. There's a lot to it. I will say that, I came back to St. Joe in September, and so it was all focused in on getting us with a good margin, right? That was the focus, because definitely in recovery time, it's time to get things right. And of course, I think what a lot of our hospitals experienced is that, labor is still a very big portion of our, expenses. And so for me, I focused on efficiencies really. And that may involve downgrading patients appropriately through the continuum in the hospital so that, they will need less resources for the nursing staff, which allowed us to move the agency on the nursing side out of the hospital. So that was a big portion of it. The physicians are very integral. We have a really strong collaboration. We meet every day, and I know Gretchen does too. And we look over all the patients and we talk about, barriers to discharge and how we're going to get them there. But we also talk about coding and things like that to properly, get them in the right DRG or whatever that is. But it's a lot about resource management. So certainly that's where the discussions come up. They need a consult for this, or they may need that. And then we look at what are our resources. We want to get those timely, prior to discharge, obviously, or set up outpatient if that's appropriate. And so I think, again, it just comes from not relying on just one area, but to have multiple areas to pull from on resources. It's really important. I think about Change Healthcare, that just happened, right?
Mm-hmm.
And that was, we all had our eggs in that basket, and
Mm-hmm.
then that basket tipped over, and it was very disruptive. So I think one thing that as healthcare providers we know is that there's always going to be disruption, and so we just really want to think about plan B, C, and so forth down the road. And I think that's where a lot of these services help us as administrators, keep us
Mm-hmm.
going so it doesn't negatively impact our operations. So.
Yeah, I agree. That multidisciplinary team approach is the key, and we do that as well. We meet every day with all the key players, anybody that's really involved in the care of that patient, both in the hospital and then post-discharge. So you'll have your PT and your OT, your case managers, all the physicians involved in home health there to say, yes, we can offer this or we can't offer that. Because I think the key to this and being successful and being able to stay in the community is appropriate resource use, meaning that you want the patient to be treated as they should be treated in the most efficient manner possible, meaning as fast as possible.
Mhm.
So if that patient needs an expert opinion, you want that consultant to be able to see that patient as soon as possible. That's how you're going to be able to have those, to diminish those avoidable days. If a patient is better and ready to go home, you want to have that transition in place so the patient stays in your hospital for 3 days rather than 4 or 5. And that's for the benefit of the patient. The last place you should be if you no longer need acute care is an inpatient stay. So to be able to utilize everything and work together to say, if this patient is medically ready now, then let's do what needs to be done to get that patient discharged to the community. The other key to that from a clinical standpoint is proper documentation. And that's one of the things that I do think Prime does very well, is educating the staff to say, if you should be documenting appropriately to show the level of care that that patient needs. So with the proper documentation education and working together with documentation specialists, we can also have our documentation truly reflect the severity of illness that the patient is experiencing.
No, it's fantastic. And I know we're coming up on time here, but I wanted to ask one last question of each of you because I love to hear where you think the future is going. What are you most excited about for your, both for your community, for your hospital on a kind of healthcare perspective? You can answer it whichever way you like, but I'd love to kind of see what you think the future holds for us here.
I'm most excited that we seem to be on the other side of COVID. We're still going to get our occasional patient, and that's fine. We know how to treat them. We will take care of them. But I'm most excited that the the number one diagnosis in the hospital is no longer COVID, because I think that's going to bring staff back. We're going to start seeing
Mhm.
students enroll in nursing school more. We're going to get those numbers back. We're going to be able to get our hospitals fully staffed again. Then we don't have to board patients so much, and we can we can provide the best possible care because we will have the best possible staffing numbers. So I'm hopeful. It's going to take some time because a lot of people made that great exodus out of healthcare because of COVID. And so we've seen a decrease in the enrollment in nursing schools. So I'm hopeful that we're going to start seeing that enrollment go up again. And it's not going to be quite as difficult to recruit our nurses. And we're going to have our nurses back and be able to serve more people.
Lorie.
Yeah. Well, I am most excited about new models of care. I think that's really where we're kind of focusing is just how to use the team concept. That's an old concept that we're kind of bringing back, but changing it a bit. How to incorporate, to make sure that we have what we need at the bedside, because without nurses, without CNAs or whatever, it's very difficult. And I always say the additional help that a nurse has is really the safety help, right? That's the
Hmm.
ones that can answer the call lights and so forth. But we're trying lots of new things. In the state of Missouri, they just put an emergency ruling to expand the LPN role, and that's going to go into full effect coming up here. And that basically allows them to do, when appropriately trained, IV pushes and other things, realizing that they're really going to be part of the team. They need an RN on the team, so we're looking at that, but more using LPNs as nurse extenders in different
Hmm.
ways. So I'm excited about that. I am seeing in our area that our nursing schools are getting full, so that's exciting. But really, just looking at having a team that can handle all the challenges, and I'm very fortunate that I have an excellent leadership team right now, and so we've been having a lot of fun trying new things and seeing what we can come up with. So I think models of care, being nursing, that's going to be a big part for us.
Hmm.
No, I think that's great. I think we see it every day where people who are willing to innovate, willing to take that risk on trying something new, because healthcare is not a place where you think of as the cutting edge of anything,
Yeah,
except maybe with
really.
drugs. But it is fantastic to work with leaders like yourself who are willing to try new care models, or who are willing to try new avenues of reaching providers, reaching patients. And you're meeting, if not far exceeding, the expectations of your community while doing it. So thank you both for your service, and thank you both for sharing your afternoon with me.
Oh, thank you.
Yes, thank you for having us.